Thank you to everyone for joining us today for the Treating Commercial Tobacco Dependence in Clinical Practice
The conference has been muted.
webinar series, which is part of the iQuits Clinical System Training Series. iQuits is a clinical systems project for commercial tobacco cessation conducted by the American Indian Cancer Foundation. It has two goals, which are to increase patient quit attempts of commercial tobacco and to increase the use of quit services, which include brief counseling during the visit, increased use of medication or nicotine replacement therapy, and increased use of referral to other services, for example, a cessation program or a quit line. The focus of today's webinar will be on the use of cessation medications and NRT. Today's presenter is Dr. Ann Joseph of the University of Minnesota. Dr. Joseph is a co-investigator on the iQuits research program. She is a Wechsler Professor of Medicine and General Internist at the Department of Medicine. She received her medical training at the University of Michigan and received a Master's of Public Health in Epidemiology from the University of Minnesota. She is currently directing the Applied Clinical Research Program in the Department of Medicine. So with that, I'm going to turn it over to Dr. Joseph for the remainder of the webinar.
So good afternoon, everyone. Thank you for inviting me to give this talk. Today, I'm going to be talking about the medication end of helping people stop smoking. We'll be talking some about nicotine replacement therapy and other medications as well, and trying to pay some attention to both efficacy, how well the drugs work, and the safety of the medications. My email is here on this slide, and I'd be happy to take questions either at the end of the webinar or feel free to message me. I have no conflicts of interest to report. So the learning objectives of this webinar are twofold: to increase knowledge on current evidence on the effectiveness of smoking cessation medications and nicotine replacement therapy, and increase knowledge of updated safety and side effect information for cessation medications. So for starters, I want to review the definition and some considerations for nicotine addiction, because I think that helps us frame some of the use of the pharmacologic agents. So most tobacco users, and I'm going to be talking about commercial tobacco use here, do a lot of behavior to maintain a certain serum nicotine concentration. Most tobacco users meet criteria for dependence on nicotine, and because stopping nicotine is associated with withdrawal, this presents a problem when people try to quit smoking. So that nicotine concentration can prevent withdrawal symptoms. It can maintain feelings of pleasure and arousal, and for many smokers also modulates mood. There is a lot of evidence that tobacco users self-titrate nicotine intake using different methods. So some people will smoke or dip smokeless tobacco or snus more frequently, for example, if they are given low nicotine products to use. Likewise, if they're given a low nicotine product, they might smoke that product more intensely because their body is accustomed to a higher level of nicotine. One of the best examples of self-titration is the so-called light cigarettes, and a lot of research has been done on light cigarettes. Light cigarettes are really a misnomer because they have the same tobacco as regular cigarettes, but the smoke that's inhaled is diluted by ambient air, and the way that is done is by making little holes in the base of the filter. But what light cigarette smokers do is they learn very quickly how to obstruct those vents, basically turning the light cigarette into a regular cigarette. So it's misleading to the public to use light cigarettes without explaining that. But it is an example of self-regulation. The symptoms of nicotine withdrawal are things that we've probably heard from patients and commercial tobacco users fairly frequently. So irritability, frustration, anger, sometimes anxiety, difficulty concentrating, feeling restless or impatient, a depressed mood, difficulty sleeping, impaired performance, particularly to tasks that are repetitive, and increased appetite and weight gain. But probably the most prominent and the most common withdrawal symptom is craving for more nicotine. These physical symptoms, withdrawal symptoms, are the most strong in the first 1 to 2 days and 1 to 2 days after quitting, and peak within the first week. They do subside within 2 to 4 weeks, and that's a very useful thing to know when we're working with patients, that as uncomfortable as they might be, that there is a finite aspect to this, and the end is in sight. But people do report some of these feelings, especially craving, over longer periods of time. So much of the work on medications is designed to treat nicotine withdrawal and avoid that portion of the challenge of quitting smoking. So there are a number of FDA medications approved for smoking cessation, but they fall into 3 major groups. One is nicotine replacement therapy, and we're going to spend quite a bit of time talking about the different formulations of nicotine replacement therapy and the differences and similarities among them. There are 5 forms of nicotine replacement therapy, but that is in one group. A second group is Bupropion, which is marketed as Zyban for smoking cessation. It's the same drug as Wellbutrin, which is the trade name that it's marketed under for depression. So that we'll be talking separately about Bupropion. And then the third group, but it's actually only one drug, is varenicline, which is marketed under the trade name Chantix. These are the only medications that are FDA approved for smoking cessation. So we, get a lot of questions from patients and tobacco users about different medications, but these are ones that have met the criteria for FDA approval, which involves being tested formally in clinical trials. For gum, it's, I think, more important to think about gum and lozenge and patch in sort of the generic version of those descriptions, because the slide is, it's almost immediately out of date when you put it together, when you put the trade names on, because there are many brands now. So the recommendation for pharmacotherapy is that clinicians should encourage all patients to use meds to quit, unless they're contraindicated or for specific populations, and we'll talk about some of those for which there is not good or insufficient evidence of effectiveness. And these recommendations are summarized in the Public Health Service Tobacco Use and Dependence Treatment Guideline. This guideline was last edited in 2008. So as you can see, it is, on one hand by chronology, sort of out of date. On the other hand, there is a remarkable lack of brand new medicine on brand new information on medicines, but I will try to update guideline recommendations with what has come in the interim. So first we're going to start with nicotine replacement therapy. So the rationale for using nicotine replacement therapy is it's exactly the same pharmacologic agent that is in tobacco. So smokers are already exposed to this. They may be getting it in a different way when we use it in a medication, but it's exactly the same material, but without some of the carcinogens and other substances that are in combusted commercial tobacco. So NRT reduces physical withdrawal from nicotine, and it eliminates the immediate and reinforcing effects of nicotine as it's used from tobacco smoke. So the concept is that it's very difficult to quit smoking, that there are components to quitting smoking that are pharmacologic and that are behavioral and that are psychological, but having nicotine on board while you're trying to do the other challenging parts allows patients to focus on behavioral and psychological aspects of tobacco cessation. So this is a busy slide, but it makes some important points about nicotine replacement therapy. So these lines show the plasma or blood concentrations for different sources of nicotine-containing products. So the gold standard, if you will, is cigarettes, and that's the green line. And what you can see is that when you smoke a cigarette, the nicotine levels go up high and they go up fast. And that's why people like to smoke, because it can alleviate withdrawal very fast and they get the brain effects of nicotine very quickly. If you compare that to other forms of nicotine replacement, you see some really notable differences. So say cigarettes are at one end of this spectrum. Patches, which is the dark blue line, the slow and steady but low, slow and steady line at the bottom of the graph, is at the other end of the spectrum. So when you put a patch on, you reach steady state levels of nicotine in 2 hours rather than less than 2 minutes. And the levels are not as high as you would typically get from a cigarette. Now, the other nicotine replacement formats, so gum and lozenge and spray and inhaler, and even smokeless tobacco or snuff, are somewhere in between those two extremes. Snuff, as you can see, can get to a pretty high level of nicotine, and there's always variability in these depending on the product and how they're used. But gum and lozenge are not quite as dramatic as a cigarette. Even an inhaler is not as effective at getting a quick blood level of nicotine as a cigarette. And it's probably the reason that our nicotine replacement products are not as popular with smokers as we might want them to be. Now, you'll notice that there is a product that is missing from this slide, which is electronic cigarettes. We're going to talk a little bit about electronic cigarettes at the end of this talk, and then there's another webinar coming up where we'll cover electronic cigarettes in a little bit more detail. So nicotine gum was the first nicotine replacement product that went on the market. It's a resin complex that contains nicotine. It's a sugar-free gum base, and then it contains buffering agents to enhance the absorption of the nicotine. So the nicotine is absorbed through the inside of the lining of the mouth, and it's absorbed best if it's in an alkaline environment. So nicotine gum is available in 2 strengths, 2 milligram and 4 milligram. And then there are a number of flavors, but the most commonly used ones are the original flavor, which actually smells a little bit like nicotine, and there's some really diehard smokers that like the original flavor. But I'd say the most popular one in our trials and in our work is mint, and then followed by cinnamon, and then there are some fruit and orange flavors. The dosing is between 2 and 4 milligrams, and as a generalization, the heavier the smoker, the better it is to use the 4 milligram gum. In our practice and in our trials, we use far more 4 milligram gum than 2 milligram gum. The reason is that, as we saw in the original graph, you don't get such a great nicotine level even from 4 milligram gum. So we're trying to alleviate withdrawal and get people feeling more comfortable quickly. So that's one of the reasons for using favoring the higher dose of gum. But in very light smokers or intermittent smokers, say 5 cigarettes a day or less, or not daily smokers, it may be advisable to use the 2 milligram dosing. So the directions for gum and the lozenge are important. And the gum is to be chewed slowly. So if it's a stiff kind of consistency, and often if people sort of chomp, chomp, chomp and really chew hard on this, they end up swallowing a lot of air. So they can get hiccups and a lot of burping and GI discomfort. So the idea is to chew until you get a peppery or minty or citrus taste, or get some tingling from the substance. Usually that takes 10 or 15 chews, and then so-called park the gum between the cheek and the gum of your mouth to allow absorption of the nicotine. So here are some advantages and disadvantages of nicotine gum, and we'll do this for each of the products. It can satisfy oral cravings. You put something in your mouth. Nicotine gum use does delay weight gain while you're using the gum. And people can titrate their therapy to manage withdrawal symptoms. So, for example, if you're just using patch, but you're having a lot of craving, there isn't much that you can do about that. But if you're using the gum either on its own or in combination with the patch, you're having a rough time or feeling very irritable, you can take a piece of gum out from your pocket and use it. Some disadvantages are that gum chewing may not be socially acceptable. I think that's probably not as true as it used to be. It can be difficult for older patients that have trouble with their teeth or with dentures to use the gum because it's stiff. And people really do better if they use the proper chewing technique to minimize the adverse effects that I spoke about earlier. So lozenge is sort of the new cousin to gum, came on the market after gum, and actually after the introduction of lozenge, what's most popular now in our practice is a mini lozenge. So it's the same thing, but just a smaller and more concentrated size. So a little bit more nicotine delivery than the gum. Similarly, it comes in different flavors, and mint is probably the, again, most popular. It also has buffering agents to enhance absorption and comes in 2 and 4 milligram doses. One of the things that's true for both the nicotine gum and the lozenge is because the absorption is better in an alkaline environment, as I mentioned, the recommendations include avoiding acidic beverages when you're using these products. So the thing that's too bad is almost all beverages are acidic, so coffee, tea, soda, fruit juices, but there's always water. Water is good, and it will just increase the absorption of the nicotine if you're using one of these products. So next I'm going to talk about nicotine patch. This is kind of the tried and true, and there's certainly advantages of using nicotine patch, and there are pros and cons of each of these products. So at the end we'll talk a little bit about how to pick and choose. Nicotine is well absorbed across the skin, and delivery through the skin, and rather than the systemic circulation, avoids some first pass metabolism through the liver, which excuse me, can help with nicotine levels. It makes for a steady state of nicotine, and those levels then fluctuate less than with smoking, and actually fluctuate less than they would with gum or lozenge used solo. So we'll get to the fact that it's often a combination of patch and one of the ad libitum forms that is effective. But for the gum and lozenge, for example, you might have to use 10 or 15 lozenges or pieces of gum a day, And as most of you can imagine, it's uncommon to be able to comfortably chew that much gum, even if you love gum and love nicotine. So there's certainly some advantages of the steady state provided by a patch. The directions are to choose an area of skin, usually on the upper body or outer part of the arm. It's best if it's clean and dry and doesn't have a lot of hair. That's mostly for sticking and not irritated. And it's best if it's an area where the person doesn't perspire an awful lot, just again, so that the product sticks well. The patch itself, and it differs, sometimes it's the nicotine, sometimes it's the adhesive, can be a little bit irritating. So it's recommended to apply the patch to a different area each day. And people will often sort of march the patch, for example, across their upper chest, and they'll see a little bit of red, go right next to it for the next day, and try to avoid using the same area for about a week. For people that do have a lot of irritation but are otherwise doing well on the patch, they can put a little bit of 1% hydrocortisone, which is available over the counter, on the red area to help speed up the skin recovery. So there are different forms of patches. Some of them are a delivery system for 16 hours, and some are a delivery system for 24 hours. In clinical trials, it's not possible to tell that one format works better than another. It's also not possible to tell whether starting with a higher dose and going to a lower dose, which is what we commonly do, works better than just putting a dose on for the entire time. So it's hard to make a strong recommendation, but I think the most common course is to do an about 8-week course of patch, starting with a 24-hour delivery system, bearing in mind that people often have strong cravings first thing in the morning. So if you use it for 24 hours, at least there's some nicotine on board in the morning. Often starting with a 21 milligram patch, going to 21 for 4 weeks, 14 for 2, and 7 for 2. Now, this is not written in stone. If somebody is on a 21 milligram patch for 4 weeks, but it's not a very solid quit and they're feeling a lot of cravings, of course that dose can be extended. And likewise, if somebody is a very light smoker, you might want to start with a lower dose. So this chart has a classification of light smokers and heavy smokers and some dosing recommendations. But in our clinical experience, I would just add that it makes a huge difference how people are doing once they start. So some light smokers can definitely have strong cravings for nicotine and need a 21 milligram patch, because you could be smoking only 10 cigarettes a day, but smoking those cigarettes very intensively and getting a lot of nicotine. And similarly, but probably less likely, but some heavy smokers are using only small portions of cigarettes. Almost everyone in our clinical trials gets started on a 21 milligram patch. We sometimes get questions, and you'll hear or see in the literature some recommendations about a high-dose patch, wearing 2 or 3 patches at a time, or trying to match a person's nicotine level with the nicotine level that they get on a patch. But trials testing that higher dose kind of algorithm don't show an improved outcome compared to these simpler ones. So we try to keep it simple when we can. So to summarize the advantages, there are consistent nicotine levels with a patch. It's easy to use and easy to conceal, and there's less compliance problems with this once daily dosing regimen. The flip side of that is that it's a disadvantage to not be able to titrate the dose. Sometimes there are skin reactions to the adhesive, and if people have really dramatic or big-time skin problems and dermatitis, it may be difficult for them to use the patch. So this combination of a patch plus an ad-lib form of nicotine is the most efficacious, particularly over-the-counter first-line therapy. It's been demonstrated that combination NRT is better than monotherapy or either one of these by themselves. So we encourage people to make a quit attempt, and on the day of the quit attempt, put on a patch and have either gum or lozenge available as a short-acting formulation. So those three forms of nicotine replacement therapy, patch, gum, and lozenge, are available over the counter. That is another advantage that I didn't mention, because even though we like to prescribe and make sure that people have these products and they're covered by insurance, sometimes we can miscalculate the amount of product they have, and people can, because they're over the counter, go in and purchase a product on their own if they need to. There are two forms of nicotine replacement therapy that I'm going to talk about now that are prescription. They are used much, much less frequently than the other three, but they're important to know about because for a few people they may be appropriate. The first is nicotine nasal spray, and this is an aqueous solution of nicotine, and it looks very much like another nasal spray like Afrin or something like that. You squirt, you put the meter dose up each nostril and just give 2 squirts. Prescription is required. It's got more rapid absorption because of it goes across the nasal mucosa, which has a very rich blood supply. But it is also extremely irritating. So people have to get used to that. The nicotine inhaler is not a true inhaler like we think of a meter dose inhaler that you would use for asthma, for example. It's a plastic tube, and you can see that in the picture, and you insert kind of a pledget that's impregnated with nicotine, and it's a cartridge that looks, very much like something that you get from the dentist after you had a tooth pulled, and then you suck on this plastic introducer and get some vapor. Now, I'm going to show you a picture of this because nicotine inhalers have been available by prescription for a while, but this is a diagram of it. You have a cartridge, you have air in, and then you have a mouthpiece. And this looks remarkably like an electronic cigarette, but without the electronic part of it. There's no battery, there's no heating source, and it's just kind of interesting because this predates electronic cigarettes by some time. As I said, we don't really see much in nicotine inhaler use, but one of the things that people refer to about this, and similarly with electronic cigarettes, is that it's more like using a cigarette than the other products, in that if you want to get some nicotine, you lift up a device, you put it in your mouth and inhale hard. So a couple special populations that I mentioned at the beginning to talk about. One is pregnant women. So we know a lot about the risks of smoking in pregnancy, which makes the comparison for medications, I think, a difficult one, because obviously we're concerned about prescribing and using medications during pregnancy, but if the comparison group is using tobacco, even if medications have some risk, they might be better than using tobacco. But the clinical practice guideline makes no recommendations regarding the use of medications in pregnant smokers. Similarly for varenicline and bupropion, which we're going to talk about, they are labeled as Category C and Category D for the prescription formulations of nicotine replacement. And so the recommendation is to offer psychosocial interventions, behavioral interventions to help people quit smoking. When obstetricians have been interviewed, especially anonymously, about what their practices are with pregnant women, however, it is clear that many do recommend using nicotine replacement therapy because of their concerns about risks to the baby. There is some reason to favor using gum or lozenge over patch, however, just because the steady state of nicotine, which may affect placental blood flow, may, in this situation, have some risks for the fetus that intermittent use with gum or lozenge do not. So that's one population. Another one is smokeless tobacco users. So there is no FDA indication for nicotine replacement or the other products for smokeless tobacco use, although they have been tested in some clinical trials. I think this is, even though there's no FDA recommendation, I think this is something that on an individual basis can be considered. You know, there's policy and recommendations from the FDA, and then those of us that are clinicians often sit across the table from somebody that is a smokeless tobacco user and has heavy withdrawal symptoms when they try to quit. If I was in that situation, I would at least experiment to see if I could help them feel better using NRT. There aren't good good data to support using pharmacotherapy for light smokers and for adolescents. So the non-prescription sales of patch, gum, and lozenge that I mentioned are restricted to adults that are 18 years or over. So quickly about bupropion. This is a non-nicotine cessation aid. It is a sustained-release antidepressant, and it's an oral medication. Bupropion is an atypical antidepressant that works through the dopamine pathway, decreases craving for cigarettes, and decreases symptoms of nicotine withdrawal. It does not work through its effect on mood. It seems to be an independent effect for smoking cessation. Common adverse effects are difficulty sleeping, so we avoid bedtime dosing, and sometimes dry mouth. There are some contraindications to using bupropion. It lowers the seizure threshold, so people with a seizure disorder have a relative contraindication to it. People with a history of anorexia or bulimia, and then obviously people that are already on the other formulation of bupropion, which is Wellbutrin or Wellbutrin slow release, have a contraindication. People that are undergoing discontinuation of heavy use of alcohol or sedatives, because that lowers the seizure threshold, also have a relative contraindication. So this is a repeat of some of those concerns: seizures, cranial trauma, people on antidepressants. So one combination that has been tested is bupropion combined with nicotine replacement therapy. So the theoretical reason this is attractive is that they work by different pathways. So maybe there would be an enhanced effect of looking at combination therapy. But unfortunately, even though there is a trend in that direction, it was not borne out to be statistically significant in a trial. What this graph shows is the percentage of people still abstinent after between 100 and 400 days. And this is a fairly typical relapse curve. Early in the game is when all the action is, when people are trying to quit smoking. So there's a lot of people that relapse in the first month of trying to quit. The top dotted line is a treatment group with active bupropion and active gum, and they look like they do the best. The next line down is active bupropion and placebo gum. And they look like they do a little bit worse, but at the end, especially, the long-term outcomes are not statistically significantly different. And then the final curve is placebo bupropion and placebo gum. And actually in clinical trials, we wouldn't even ethically include an arm like that anymore because of the demonstrated efficacy of therapies. So varenicline, this is marketed as Chantix, and this is a non-nicotine cessation aid. It is a partial nicotinic receptor agonist, and it's also an oral medication. So for both bupropion and varenicline, one of the things to remember is that they are starting, you start the medication about 1 week before the planned quit date. There have been some concerns about varenicline that led to a black box warning. In the early marketing phase of varenicline, there was what looked to be a large number of reported neuropsychiatric symptoms to the FDA, changes in mood and episodes of psychosis and agitation and suicide attempts that were reported. These were all obviously single cases that came to the FDA, and so there was no control group. And as you probably know, a large number of people that use tobacco have mental health problems. So it made it difficult to evaluate whether or not this was because of varenicline or because of the underlying characteristics of these patients. We finally have, and I'm sorry, I'm going to go back for a second. Severe error here. Hang on 1 sec.
Okay. Just click that. Yep. Should be okay. Looks fine here.
But I don't have any slides.
Double click here.
Hang on for a second, everybody. Maybe I shouldn't go back. I was on.
You're on this one.
Do you have it?
Yeah.
Okay. So, okay. I don't. How do we know
it's still working?
Okay.
Yeah.
Okay. Sorry about that. I can't see the slides, but apparently you guys can, so that's good news. And please write something in the chat box if that doesn't turn out to be the case. So we have a new set of results from something called the EAGLES trial, and because of these psychiatric symptoms, the FDA actually obligated the industry to do a trial, and it was a huge trial, including international sites. 8,000 patients, approximately half with psychiatric disorders and half without psychiatric disorders, and compared varenicline to bupropion to nicotine patch to placebo. We have very few examples of these kinds of comparison, head-to-head comparison trials. So this was interesting for a number of reasons. But the important thing was that there was not a increase in adverse events, psychiatric or otherwise, associated with varenicline. It also looks like varenicline is more efficacious than the other agents, and so this is an important finding that is borne out by some other studies, that there may be a cessation advantage for varenicline compared to the other agents, certainly compared to placebo. So I'm just going to look at the long-term quit rates for the different cessation medications. And the exact numbers here will vary by study and by meta-analysis. These are from a Cochrane review, and I'm more of a lumper than a splitter, but on overall, the medications approximately double quit rates compared to placebo. So again, this provides good evidence, I think, for using medications compared to not using medications. The pharmaceutical companies have been conscious of the costs of medications, and this slide compares the daily costs and shows that they come out roughly the same. There is, under the Affordable Care Act, there is reason to pay attention to helping patients get insurance coverage for smoking cessation medications, which they are entitled to. So I don't want to leave this topic without reminding people about behavior change. We've talked a lot about medications, but fewer than 5% of people who quit without assistance are successful in quitting for more than a year. So it's important to pay attention to the other counseling parts of the cessation attempt. That helps people prepare and plan for their quit attempt. It helps them learn more about their behavior and the cues that are personal for them for smoking, and discounts the notion, which is really effective, that patients can just make themselves quit. So behavioral counseling, even though it's not what we've spent time on today, is a key component of treatment for tobacco use and dependence. These are some of the features that often come up in counseling. So difficult situations like drinking coffee, waking up in the morning, driving, boredom, stress, drinking alcohol, work breaks, being on the telephone, or being with specific family or friends who smoke. And counseling can help people learn to deal with these situations. I mentioned that we're not going to talk about electronic cigarettes a lot, but I'm just going to mention a couple of things before we stop for questions, because almost inevitably we will, as clinicians, get some questions from patients about whether they should quit or whether electronic cigarettes could help them quit. So we don't have the bottom line on this very important topic yet. It's disappointing that there are really only 2 clinical trials on cessation published on electronic cigarettes, and they're both pretty old considering how much action there's been around electronic cigarettes in the last few years. There are 7, I just learned at the tobacco research meetings that there are 7 trials ongoing currently, but the 2 that have been published, they compared, they differ in minor ways, but compare electronic cigarettes to some to with or without nicotine electronic cigarettes, and some to nicotine replacement therapy, and then look at outcomes a little bit down the line. And as far as cessation for the ECLAT study, the first one that was conducted in Italy, the quit rates were not statistically significantly different in the treatment groups. In the New Zealand study, similarly, there were not significant differences between the treatment groups. There are other data, however, that are not from clinical trials that have been published more recently from the UK. And these are observational data that show the increase in electronic cigarette use for quitting that is reported just on a population basis. And so you can see in the bottom frame that starting in 2012, there's quite a large bump in electronic cigarette use. And that is associated with a modest increase in quit attempts. That's the blue line in the top panel. Now, there are a lot of difficulties with the methods of using observational data to look at this question, because there may be self-selection of smokers who are using electronic cigarettes as people that tolerate them well. So this is still a moving target. The clinical approach that I would recommend for patients that are asking is to remind people that the medications that have been approved by the FDA have been shown in rigorous trials to be effective, and so they're first line of therapy. If somebody is really up against a wall of they're only willing to use electronic cigarette to quit, I would rather have them do that than do nothing. And if that's a way to engage them in the process of quitting, I think that that's okay on a individual basis. But we can spend some more time talking about that in the next webinar. So I'm going to stop there, and we have time, I think, for questions.
All right, thank you, Dr. Joseph. This is Megan. We're going to just stop the recording really quickly and then unmute you all and open it up for questions if there are any.